Well, hello. It is my pleasure to welcome you to today's webinar. The RADx-RAD Recover Working Group is excited to launch the Long COVID Computational Challenge, also known as the L3C. Thank you for your interest in this challenge. This webinar will provide some background and objectives of the challenge, information on how you can participate, and the prize purse totaling up to $500,000. We welcome everyone to participate in this challenge. Some rules of the road for our Zoom interaction. The webinar will be recorded. All participants except the speakers and the panelists will be muted. Auto closed captioning is available. To view, click the live transcript button. Use the questions and answers function to ask questions and upvote. Questions will be answered during the Q&A session later on this webinar. The recording and the slides from today's webinar will be posted in the website listed. See challenge.gov for more information on the L3C challenge. My name is Orlando Lopez. I am a program officer with the National Institutes of Dental and Craniofacial Research and one of the co-chairs of the RADx-RAD Recovery Working Group organizing this Long COVID Computational Challenge. I would also like to introduce fellow presenter in this webinar, Dr. Tim Bergquist with Sage Networks, as well as panelists from NIH who will help address questions from the audience during the Q&A session, including working group co-chairs, Drs. Yvonne Schulman and Dr. Erin Iturraga, and working group members, Dr. Josh Vessel, Tyler Gilliland, and Asif Rizwan. Also like to acknowledge the NIH leadership for their support and the RADx-RAD Recover Working Group and all those who contributed their time and effort to the launch of this initiative. This webinar will walk through background objectives of the challenge, as well as details on administration and eligibility, and we'll leave some time for Q&A. The NIH Long COVID Computational Challenge is a community challenge. A community challenge is a crowdsourced benchmarking effort which aims to accelerate research by seeding or strengthening a research community and addressing an important scientific or biomedical question. The format of a challenge is broken into three parts: the question, the build, and the benchmark. The question is the research question that the challenge organizers pose and is the guidelines that focus the research community to the topic the NIH is interested in. The build is the portion of the challenge where the participants build a method to answer the challenge question. And the benchmark is a portion of the challenge where the challenge organizers judge the build or the method the participants created against a set gold standard. The challenge intends to accelerate innovation of software tools to improve understanding of risk factors and support the clinical prognosis of long COVID or PASC or post-acute sequela of SARS-CoV-2. Now for an overview of the L3C challenge. PASC, long COVID. Here's some background. The overall prevalence of post-acute sequela of SARS-CoV-2, known as PASC, and also known as the long COVID, is currently unknown, but there is growing evidence that more than half of COVID-19 survivors experience at least one symptom of PASC or long COVID at 6 months after recovery from acute illness. Long-term effects and persistent symptoms of COVID-19 can affect anyone, including children, and it can develop in people who had asymptomatic, mild or severe COVID-19. Reports also reflect an underlying heterogeneity of symptoms, multi-organ involvement, and persistence of PASC and long COVID in some patients. Symptoms of fatigue, cognitive impairment, shortness of breath, and cardiac damage, among others, have been observed in patients who had only mild initial disease. Despite ongoing research, a significant need remains in identifying prognostic factors that can reliably support clinical decisions for the management and prevention of past long COVID in SARS-CoV-2 infected individuals. The breadth and complexity of data created in today's healthcare encounters require advanced analytics to extract meaning from longitudinal data on symptoms, laboratory results, images, functional tests, genomics, mobile health wearable devices, written notes, electronic health records, and other relevant data types. Advanced development of software tools and computing capacity has allowed artificial intelligence machine learning approaches that are increasingly demonstrating the potential to provide insight into patient-level data from large amount of data to better understand the effect of SARS-CoV-2 on patients. To complement other NIH long COVID research initiatives, like researching COVID to enhance recovery, known as the Recovery Initiative, the RADx-RAD program at the NIH launched the Long COVID Computational Challenge, the L3C, to support creative data-driven solutions that meaningfully advance the current understanding of the risk of developing past long COVID. Challenge participants will utilize de-identified electronic health record data available through the National Center for Advancing Translational Sciences, NCATS, N3C Data Enclave. The N3C Data Enclave is a central harmonized data repository that represents electronic health records from over 74 health centers across the United States. To protect patient privacy, de-identified data provides information useful to researchers without revealing any information that could identify individual patients. Further information on the use of the N3C Data Enclave for purposes of the challenge will be addressed later in the data section of this webinar. The objective of the L3C challenge is to focus on the prognostic problem by developing artificial intelligence, machine learning models, and algorithms that serve as an open source tool for using structured medical records to identify which patients infected with SARS-CoV-2 have a high likelihood of developing past long COVID. Understanding risk factors may help clinicians better understand the underlying etiology of past or long COVID. Models will be evaluated using patients who have an ICD-10 code recorded in the dataset to label true positive of patients with past or long COVID. Future funding opportunities related to this topic may become available beyond the challenge announcement, depending on the state of the science, public health need, and availability of funds for further development of models and algorithms into clinical decision support to predict the development of past or long COVID and improve understanding of the clinical outcomes and the effectiveness of early interventions in preventing past or long COVID. This challenge invites solutions that explore the probability of developing past long COVID among patients who have tested positive for SARS-CoV-2 in an outpatient or inpatient ICU or non-ICU setting. So what definitions will be used? The working definition for past or long COVID continues to change with new evidence and is challenging given the multi-organ effect seen in this new condition. COVID-19 positive, we define COVID-19 positive patients as patients who have had a positive COVID-19 PCR test, not just a diagnosis. PASC or long COVID, we define patients who have an ICD-10 code recorded in the dataset are labeled as true positive patients with PASC or long COVID. There will be further explanation of this in the data section coming up shortly in this webinar. Challenge participants are expected to develop, train, and test their models to aid in the prognosing the susceptibility to and likelihood of developing past or long COVID in patients with SARS-CoV-2 infection. The eligibility rules are listed here and can be found at the link at the bottom of the slide on the respective websites. Please be sure to review all the eligibility rules. Send any questions to the challenge administration team listed at the bottom of the slide. The challenge participation rules can be found at the link below. Challenge.gov website under the Rules tab. Special attention should be paid to participation rules 9 and 14. Rule 9 states concerns related to submissions of winning algorithms and documentation to an open source platform. It states that by participating in this challenge, each participant, whether an individual, group of individuals, or entity, selected to win a prize under this challenge agrees to deposit their code for the models submitted to an open source platform, like GitHub. The code will be made available to the public under the open source license. Payment of the prize is contingent upon successful depositing of the code. As part of the submission requirement, each participant will submit their code and a report summarizing their method. Sage will facilitate loading the open source to the open source platform. Rule 14 concerns policies governing the N3C enclave, including data use agreements. Follow all N3C data policies for publication in the respective website listed here. To access data within the N3C data enclave, an authorized institutional official from the participant's home institution must sign the N3C data enclave institutional data use agreement, or DUA, and agree to the terms of service outlined by the NCATS and N3C. Participants must agree and abide by the N3C data user code of conduct, challenge data use request, and complete required trainings. Please be sure to review all participation rules. These can be found on the challenge.gov website under the Rules tab. Send any questions to the challenge administration team listed here in the slide. Now that you have an overview of the challenge, I will pass it over to Dr. Tim Bergquist from Sage Networks to review details on the administration of the challenge.
Thank you, Orlando. So the Long COVID Computational Challenge will be hosted in the National COVID Cohort Collaborative Data Enclave. This represents electronic health record data from over 74 sites from across the U.S. and contains over 15 million patients, including 5.8 million COVID positive patients and 17.5 billion rows of data. The data has been de-identified to protect identifying patients. The data includes common clinical records such as demographic information, procedures performed, medications prescribed, and conditions diagnosed by medical professionals. The data follows the OMOP version 5.3 common data model, which you can find more information at on the odyssey.github.io website. This website contains detailed information about the common data model, the tables used, and the columns inside of those tables, as well as vocabularies used within the common data model. For this challenge, we are using the ICD-10 code U09.9 to identify patients who have been officially diagnosed with PASC for long COVID. This ICD-10 code is also known as post-COVID-19 condition. One thing to consider as you build your model over the next few months is that not all patients who have long COVID have been diagnosed, but they could be available in this data set. The U09.9 is given to patients who have been officially diagnosed by a medical professional, and so there may be many patients in the N3C data set that have not been officially diagnosed, but do have long COVID. So make sure you keep this in mind as you're building your models. For this challenge, we'll be giving you 3 data sets that you can use to build your model. Overall, we will not be giving you access to the full data enclave data set. What we will be doing is we'll be selecting a version of the data. So the data is updated on a bi-weekly basis. And so we'll be freezing the data set to around July 31st. And from that data, we'll be selecting all patients who have a code U09.9, as well as 4 times as many patients who have not been given the long COVID diagnosis. We'll be randomly selecting these non-long COVID patients, and we'll be matching visit distributions with the long COVID patients. So in the long COVID cohort, for the number of patients who have 0 visits prior to their COVID index date, and the number of patients who have 1 visit, 2 visits, 3 visits, those percentages will match in the non-long COVID cohort. We're doing this in order to limit the amount of computational overhead for people who are first starting to develop their models. As the challenge continues, we may start bringing in more long COVID patients to give people more data to work with, but this is only contingent upon upon teams becoming more and more efficient with their models. We'll take this data set, this 1-to-4 ratio of long COVID and non-long COVID patients, and we'll split it into we'll put it into 2 data sets. There'll be one version of this data set called the uncensored training data. This will include all the data that I've just referred to, and it will include all the clinical records available in the version of the L3C data set that we're pulling from. The censored version of that data will remove all data that is included in the patient's clinical record 4 weeks after their initial COVID index date. If you're still confused, there will be a visualization in the next slide that will hopefully clarify this. We'll also have a censored version of the testing data. However, the testing data that you'll be given is a placeholder. It is a subset of the training data and will not represent the testing data that we'll be using to actually test and validate your models. That data will be pulled in after the initial model development phase with the new prospectively accumulated data. So over the course of the challenge, the data in the enclave itself that you do not have access to will be accumulating every week with new patients, more long COVID patients, more non-long COVID patients. And at the end of this model development phase, we'll be pulling in that new accumulated data, pulling it into the censored testing data set that you'll be using and replacing it. And then we'll rerun your models on that new testing data to evaluate how well your models perform on the new incoming testing data set. To highlight the difference between the uncensored data and the censored data, here's this graph. Uncensored data means that we will give you all clinical records available at the time that we pull the data from the main enclave data set, including visits 4 weeks after the initial COVID diagnosis or the initial COVID positive test. The censored data will include all data up to and including the first COVID positive visit or the first COVID measurement or positive measurement, as well as data that 4 weeks after that initial COVID positive visit. But we'll be removing all data after that first 4 weeks. So to reiterate, when you build your model, we want you to use the censored training and the censored testing data, and we want you to use the data available at the time of COVID diagnosis, as well as the initial 4 weeks after that COVID diagnosis. You can use all data available in those time windows to make your predictions on the testing data to predict whether patients are at risk for developing long COVID after the initial 4 weeks of the COVID positive test. The reason we include the uncensored data is so you can potentially identify other patients that you want to use and have a full context of those patients in your training data set. In order to register for the challenge, there are 2 broad steps. Each of those steps has sub-steps. So the first thing you need to do is you need to register within the Synapse platform. Synapse is a collaboration platform run by Sage Bionetworks, and we use this platform to run challenges, organize collaborations around large data enclaves. So the first step you need to do is to create a Synapse account. This is pretty simple. You can use either your Google account or your university or institutional email or your company email. Then you have to click the register button that will add you to the challenge team, on the back end, it will actually register for you the challenge. And then for step 3, you need to create your team. So even if you're the only person on your team, you need to create a team, and there's instructions there on how to create a team. And then once you have your team captain needs to register your team for the challenge. So there are 2 registration steps. You need to click for yourself to register for the challenge, and your team has to register for the challenge. And there's more instructions there. The next phase is to get onboarded into the N3C enclave. These steps are available on the synapse.org/L3C website. The first 2 steps have to do with your institution entering into an agreement with N3C, and the last 3 steps are you, the individual, onboarding into the N3C enclave. So the first 2 steps can take multiple weeks depending on how quick of a turnaround your institution has. You need to have a signed data use agreement. If your institution already has a signed data use agreement, this will appear on the list that you can see at the Check DUAs link. If you do not, you can find more information on how to get your institution to sign a DUA at the Information for DUA button. And all this is, again, available at the synapse.org/L3C website. If you're a citizen scientist and you are not affiliated with an institution, there's additional information on how you can go about being onboarded into the N3C enclave. Step 2 is to make sure that you have the proper IRB approvals. Whether you need an IRB approval for de-identified clinical data is up to your individual institution, so make sure you check your research policies. In my experience, these first 2 steps can take multiple weeks, so I recommend you start today to get your paperwork in order if it's not already in order. The last 3 steps are you, the individual, being onboarded into the N3C enclave. So first you need to register with N3C. You can go to that registration button there, and it will walk you through the steps of what's needed next. You then need to have the required trainings. So there's one training, that's the NIH Information Security Training, that is available at the link there. And make sure that you save at the end, they'll give you a certification document. Make sure you keep that for your own personal records and for onboarding into N3C. There's also a human subject research training required, and that will be made available to you through your home institution. The final step, after everything else is complete, is to request to join the challenge project. You can go to the request access button there, and it will take you to the data use request form that I will show in the next 2 slides. Just to highlight how long this can take, in my experience, oftentimes the IRB and the DUA paperwork can take upwards of a few weeks, if not a full month, to get all that paperwork in order in the home institution. Normally, when the paperwork's all ready to go, on the N3C side, once that's submitted, it only takes a few days. So make sure that your DUAs are being signed on the back end at your home institution. If you've never used the N3C platform, there can be a substantial learning curve to understanding how this system works. I recommend you do not take this for granted and do not put off learning the N3C enclave system. It can take about a month to get fully onboarded, fully understanding the system, and then after that full month, then you actually start building your model. So just to kind of light a fire under you, to get your paperwork in order and start the tutorials as fast as possible. If everything goes in a worst case scenario, you'll be 2 months into the challenge with 1 month left to go in the challenge timeline, and you only have about a month to actually build your models. So I recommend you get this going as fast as possible. Start out the tutorials, start learning OMOP to try and speed up this learning curve so that you can give yourself as much time as possible to develop your models. When you click on the registration button in step 5, it will take you to this data use request, this existing data use request. And you'll know it's an existing data use request because it will say so, and it will have the project title RADx Long COVID Prediction Challenge. If somehow you find yourself on a different data use request that's that's asking you to create a new one, you are on the wrong page. Do not create a new data use request. That will be rejected, and you'll have to go through this step again. Once you are now onboarded and you've signed the data use agreements and all your paperwork's in order, you'll have access to the RADx Long COVID Prediction Challenge project. In this project, you'll find 4 folders. The first folder is the challenge data. In here, you'll see 3 folders: the uncensored training data, the censored training data, and the censored testing data. These will contain the data sets that I described earlier on in this presentation. You also won't see the organizers folder, but this is just a folder that I have access to start developing materials for use and to do model evaluations. The resources folder, it will be available to you, and in here you'll find multiple documents detailing challenge instructions, example workflows of what we expect your submissions to look like, and possibly more details on how we're going to be scoring your models, as well as additional resources such as tutorials, links to tutorials, and also information on what tools within the enclave you should be focusing on in order to learn how best to use the system. And finally, there's the Teams folder. Once you're onboarded, you will have your folder in this Teams folder, and it will be named after whatever team name you have in Synapse. And in that folder, you can then do whatever you need to do. You can build your models, pull in data, run experiments, visualizations, whatever it is, and do your data explorations to start developing your model. You will see other teams folders in there, and you will actually be able to click on them and view file names and folder names. But if you were to click on one of those files, it will say you do not have permission to view it. So you can go through, so if you're really paranoid, you can name your files something generic so that other people can't glean any information about what your file might be doing. But just have that in the back of your head. As far as what we expect you to submit to the challenge, excuse me, we expect you to submit a workflow that ingests the two data sets, the censored training data and the censored testing data. We expect you to take these two data sets and use those in your model development. So most workflows are going to have the importation of those training data. Then they're going to have some sort of data processing workflow that either does feature engineering, data cleaning, or data filtering. And then you'll have another two steps. The first one will be your model fitting, where you actually build and develop, you actually fit your model to the data. And then a second step where you take that model and make inferences about each person in the censored testing data, making predictions about whether they're at risk for developing long COVID after that initial 4 weeks after their first COVID positive test. At the end, we expect one file of patient predictions where you have a person ID and a score from 0 to 1 with the likelihood that they will, where the score represents the likelihood that the patient is going to develop long COVID. We expect one prediction per patient from the censored testing data. And you can use the person table from the censored testing data to make sure that you're giving a prediction for every single person ID in the data. More detailed example code will be available in the resources folder, and we'll be going through this workflow in more detail in an upcoming orientation that will be announced in the next couple of days. Finally, we'll be discussing here the evaluation metrics that we'll be using. So we'll be looking at quantitative metrics, the classic calibration curves, mean error, Breyer scores. We'll also be looking at area under the precision recall curve, area under the receiver operator curve, as well as breaking out those individual components into specifically precision, recall, sensitivity, specificity, looking at all of those in a holistic manner to see who had to evaluate which models are the most accurate in terms of quantitative metrics. And we'll be also looking at qualitative metrics along two vectors. So the first one will be utility, and we'll be evaluating models on how useful they will be in a clinical setting. We'll be looking at whether we can understand what features are driving feature prediction or model predictions, as well as how relevant those features are in a clinical setting. We'll also be looking at the timeliness of the predictions. So we'll be asking the question, is your model only accurate on patients where the long COVID diagnosis is the next day after that 4 weeks, or are you able to make predictions a month into the future? We'll also be looking at context utility. So we'll be breaking down the long COVID cohort into sub-demographics. So we'll be looking at how models perform on pediatric populations, how they perform across different racial groups and ethnic groups, across different age brackets, not just children, but also the elderly, middle-aged, and pediatrics. We'll also be looking at whether models perform differently across different severity groups. We'll be looking at how accurate models are, whether patients came into the emergency room or whether they were just in an outpatient setting, the level of information available. We'll be looking at a lot of different chopping. We'll be chopping the data along many vectors to see how well your models perform across those different substrata. And we'll be looking at the likelihood of implementation. This can be kind of a difficult one to assess, but overall, we're going to be asking, if this model were to win and we want to implement this into a clinical setting, what is the likelihood that of success of implementation? So if you have a model that takes 2,000 features, has 100 layers in a deep neural network, that's most likely not a high likelihood of success for implementation. But if your model is a simple linear model and it takes 4 features, we would say that's a very high likelihood of implementation, but you're probably sacrificing a lot of accuracy. And so we encourage you to think about, when you develop your models, not just trying to maximize accuracy, but also thinking about how your model is going to be used in the future. So what this means is that the most accurate model may not come in first place, but it'll be a combination of whether we think your model is most likely to be accurate with some sacrifice to accuracy. We'll also be looking at reproducibility. So how reproducible is your model? Are your methods clear in your write-up? Can we understand what it is you actually did with your feature engineering and your model development? How clear is your documentation? That includes comments in the code. Can we understand what it is your code is doing? When we rerun your model multiple times, are the predictions more or less the same with some variance, or is it a static output, or is there a wide variance every time we rerun your model? And technical reproducibility. When we pull in that new testing data set, does your model break because there was some unforeseen change in the data and the underlying data distributions? So we'll be looking at those 2 vectors in qualitative measurements. For the prize, there's a total prize purse for this challenge of $500,000. First place will be receiving $200,000. Second place will be receiving $150,000. Third place will be receiving $100,000. And there will be an honorable mentions prize pool of up to 5 distributions with a total of $50,000 for that honorable prize mention. These honorable mentions will be at the sole discretion of the challenge managers. These don't have to be 4th or 5th place. These could be honorable mentions of models that did uniquely well on pediatric populations, or were uniquely fair across multiple racial groups. Or maybe there was a very interesting method that we really, really liked, but it didn't quite fall in the top 3. And so we want to give a methodological honorable mention. It could be interesting feature engineering, or an interesting way about how you thought about how your model could be implemented that you talked about in your write-up and did some extra validation to prove that your model could be used to identify specific treatment paths. There's a wide range, and we're hoping that this prize pool encourages you to get creative with how you break up the data, or how you think about your model being implemented in a specific setting. But there is a prize, that is available if you don't think you're going to be able to hit the top 3. And this will be anywhere from 1 to 5 prizes given, with equal distribution of that 50,000 to those honorable mentions. The challenge timeline, obviously, we launched the onboarding phase in August, where we allowed people to start beginning the process of getting onboarded into the enclave. If you've been onboarded into the enclave, you will have had access to the data now since September 15th. And so as you get onboarded, you'll be able to have access immediately to the data. Obviously, the webinar is today, and we'll continue to have people developing their models until December 15th, when we will cut off access to your team folders, and you won't be able to make any more changes. So make sure that your models are in the submission, in your submission file, or in your submission folder. Make sure everything's in order. All your write-ups are finished by the 15th. I would suggest a few days earlier. In previous challenges in the L3C enclave, we had people making edits at 11:59 on the 14th. So I'd make sure all your submissions are in order in your submission folder by at least the 14th. And we'll be evaluating and judging your models all the way through till March, when we'll announce the winners. Finally, there'll be some additional learning opportunities if you don't find this sufficient, or if you're not familiar with the enclave. We'll be hosting multiple tutorials and orientations over the coming weeks. An email will be going out with those dates and times, and those sessions will also be recorded and made available. We'll be going over things like how to build efficient models to manage memory, what the different tools are available in the enclave, what the data looks like, And we'll be going into detailed submission workflows to highlight what it is exactly we want you to be doing in the enclave to make your and how we want you to make your submissions. There's also the resources folder I mentioned earlier, where you can find additional instructions and tutorials on what we want from you in the challenge. There'll be a submission example, as well as links to the learning portal that is available in the enclave. And if those aren't sufficient to you, we'll also have I'll also be hosting office hours every Thursday at 10 a.m. Pacific time, starting on the 29th. The link is here if you want to register for and get that on your calendar. But also the link can also be found on the synapse.org/L3C website. That link will take you to a registration page where you can sign up and get that event on your calendar. I encourage you to come. It'll be very informal, and you can stay around as long as you want and ask whatever questions you need. And now I invite our panel to join the call to answer questions. As a reminder, if there's any questions, you can enter them into the chat and we'll be glad to answer them. Thank you very much.
Thank you. So welcome to the L3C Q&A session. My name is Dr. Yvonne Schulman. I'm at the National Institutes of Diabetes and Digestive and Kidney Diseases. And I would like the panelists to please briefly introduce themselves. Maybe we could start with Tim Berquist.
Yes, my name is Tim Berquist. I'm a research scientist at Sage Networks, and I'm the challenge administrator for the L3C.
Thank you. And Dr. Josh Fassel.
Hi, thanks for attending the webinar. My name is Josh Fussell. I'm the Senior Clinical Advisor in the Division of Clinical Innovation at NCATS, the National Center for Advancing Translational Sciences.
Dr. Taylor Gilliland.
Hi, everyone. I'm the Senior Advisor for Innovation Programs at the National Institute of Biomedical Imaging and Bioengineering, and also serving as the acting NIH Challenge Manager.
And next, Dr. Erin Iturriaga.
Hi, thank you for attending. I'm Erin Iturriaga. I'm a program officer and clinical trial specialist, as well as a co-chair for the Challenge Prize. And I'm at the National Heart, Lung, and Blood Institute.
Thank you. And Dr. Orlando Lopez.
Hi, everyone. Orlando Lopez. I'm a program director with the National Institute of Dental and Craniofacial Research and one of the co-chairs for this working group. Thanks for attending.
And last but not least, Dr. Asif Rizwan.
Hi, everyone. I'm Asif Rizwan, Program Officer, National Heart, Lung, Blood, and Sleep Institute. Thank you.
Thank you. So I just want to remind everyone to please use the upvote feature to highlight your question that you would like answered. So we're going to start with the ones with the most upvotes. I also, we have some that we already have gathered. So we'll start with how are data sets, how are dates for occurrences handled given de-identification? And does the data include the identified hospital or facility ID? And does the data include unstructured records, for example, clinical notes? And Tim, yeah, Dr. Berquist, please.
Yeah, so the data is de-identified. That means that the data that you have available to you has been date shifted. So it's been date shifted by plus or minus 180 days, something in that range. Each patient record or each patient and all the records have been shifted by the same amount on an individual level. So the relative differences between the records on a patient level are the same, or are the same across in each of the records. You will have access to it's called data partner ID. So you'll be able to you'll be able to break up data by participating or contributing data sites. The other thing was, sorry.
The de-identified hospital facility ID and if the data includes unstructured records, for example, clinical notes.
Yeah, that's a brand new thing, and currently it's not in the data set. I just realized that's just recently been added, like in the past few weeks. So so that will be in there, I think, by the end of the day. Not the unstructured data itself, but what it does look like we can have available is what's called Note NLP. And these are terms that have been pulled out of the clinical notes that are now in a table that is part of the de-identified data. So I'll be pulling that in later today. You won't see that right now, but it'll happen.
Can data be transferred to a local data center? If not, do we have access to GPUs on the platform?
So you cannot download the data to your local, you cannot download patient level data. You can request to download aggregated data, but you have to go through a data download request process. So in order to use patient level records, you have to use it inside of the enclave. There are compute resources available in the enclave. So at a future tutorial, we will show you, if you're not already familiar with the enclave, we'll show you kind of what that looks like, what a code workflow looks like, what a code repository looks like. And then there are some GPUs available, and that'll probably be another topic for another tutorial session. By the end of the day, the resources folder will come online, and there's going to be some highlighted tutorials that are available in the enclave in the learning portal. And I believe there's some tutorials in there for how to work with GPUs. So those will be available. Well, those are available if you're in there.
I have a related question. Do you provide an API?
So the way the enclave works, so I mentioned in my talk that there's a learning curve. So the reason there's a learning curve is because it's not just like a Jupyter notebook that you can just write code in and then just run it. There's a certain way you have to think about how you write your code. It's you have to break your code out into what I call data transforms, and but you have to work within sort of the restrictions of the enclave. And so you work inside of these environments where you can run these code workflows, and inside of that environment you can pull in specific settings like GPU settings or high memory settings. You can pull in different libraries, and so then you can work your code inside of that system. So there's APIs in the back end, but you don't specifically work with APIs most of the time.
Thank you. So can we still sign up even if our DUA is in process? Flow institution.
You can register for the challenge, but you're not going to be able to work inside of the enclave. You have to have the DUA, unfortunately. Or, yeah.
And will access to the data via the enclave be available to researchers beyond the end of the challenge for future work?
So once you have access to the enclave, you can actually make a request for another project if you want. So after the end of the challenge, we're going to shut everything down for about, I think, 3 months until March when we announce the winners. Afterwards, we'll most likely be we'll reopen everything back up so you can come back in and look at things. But if in the meantime you want to continue your work, you could open another project or request another project in the enclave and then start doing a separate in like a parallel project in that way. But during that initial 3 months of judging, you won't have access, but afterwards you'll have access again.
What if someone has already onboarded before for other projects to L3C?
Yeah, so you should already have a DUA in place. What may be a limiting factor is whether your home institution requires you to have an IRB for de-identified clinical data research. If you haven't already done, make sure that that's in place, but it should be a lot more simple this time. So you can just go to the synapse.org/L3C site, go to the how to participate, and then at the very bottom, you should just be able to go to the DUR and request access and fill that out.
Okay,
So,
next question. Can we publish our findings?
yes, you can publish your findings. There is a publication policy on the Synapse site that you can go read. It's not super detailed, or it's detailed enough, but there's not a lot of requirements. So you'll be able to publish your findings. We are going to be working on a flagship manuscript that will kind of describe the findings of the challenge. And if we get that done fast enough, ideally, when you publish your paper, you would cite the flagship paper.
And I'm getting several questions on medical images. Does the data have medical images, for example, chest CTs?
Not at this point. Yeah.
Okay.
That's right. Hey, this is Josh. Sorry, yeah, that's correct. Not at this point. And I was also going to add that I see a lot of questions in the Q&A about sort of what kinds of data are available, what do the labels look like, all that sort of thing. I would encourage everybody, if you're not already quite familiar with the National COVID Cohort Collaborative with N3C, to go to the N3C website and spend some time on that website, because a lot of these questions, you can find some good information to address on that website as well. And you may find that really helpful.
There's a question, I saw a few questions about the 4-week window. Here is one that says, if prediction is on patient level, what about patients with multiple COVID infections? How would you pre-process given the 4-week window?
Yeah, at the moment, the COVID index, I think, is the minimum. Yeah, I think there's an argument, I think, to be made for both of them. Because if in theory, you could go with the minimum, you could go with the first one, because they may get long COVID after that, or you could go with the maximum and then have long COVID after that. Right now, we're going with the minimum COVID index. But you'll be able to see all the COVID, you'll be able to, so if you go to the uncensored training data, you'll be able to see how many, all the patients and all their data available. I'm not cutting anything off. In the censored data, it'll be cut off 4 weeks after their initial COVID diagnosis.
Okay, next question. How many submissions can be made per team? In other words, will teams be able to determine how well their models work on the blinded evaluation data?
No, so you can submit one workflow per team, and we're not going to, and no, you won't be able to see how your models perform on the validation data that we pull in, the prospectively collected data, until after we finish the judging.
Okay. Next question. From a model workflow goal point of view, is the prediction window limited to 4 months after the first positive encounter of COVID?
4 months?
That's based on the definition of, I'm assuming they're going by some definition of long COVID.
Sorry, I'm trying to find the question here so I can get it. Is the prediction window limited to 4 months after the first positive encounter of COVID? No, so it's 4 weeks. So you can use the initial 4 weeks of data after the COVID index, and then from there, we want to make a prediction about whether they're going to have whether they have long COVID or not. Yeah.
Okay. Is there a limit on the number of members per team?
Nope.
And another question on the weeks. So does that mean our prediction window is limited to 4 weeks? Seen a few of those questions.
No. Wait, so I guess I'm confused. So the prediction window, so you have your model will use the data within the first 4 weeks after their initial COVID diagnosis, and then you're making just a prediction after that. So if you're not making a prediction for the next 4 weeks, you're just making prediction for just in the future, are they at risk for long COVID? So yeah, so I think because there are some cases where someone comes back in after that 4 weeks and they have a PASC code, but it's like 200 days later. So we're kind of on this rolling window after the initial 4 weeks. That there's some codes that come in that are pretty far outside of that data or out of that window.
So another question on data. I understand that the data has been time shifted, but can we know the actual time range of the data? For example, 2021 to 2022.
You'll know within about 6 months. So do you want the year? You just want the year of the data, or you want like the month of the data? Because at the moment, that's not included in the de-identified data.
So a question on eligibility. Do you have to be associated with an institution?
Yes. If you're a citizen scientist, in order to get the DUA signed so that you can get access to the de-identified data, you do have to be working through an institution. If you're not associated with the institution right now, you can go to synapse.org /L3C, There's additional instructions on what citizen scientists can do in order to get, we can help facilitate you getting access through an institution. So if you're still having issues, you can shoot us an email at the Radix admin email. I forget exactly what it was. But you can shoot us an email. We can help facilitate that.
Okay, another question on data. Do you have any sample, even fake data, that we can look at while we wait for all the paperwork to be done?
So if you're not inside of the enclave, we won't be able to give you won't have access to any data inside of the enclave. If you have never worked with the OMOP Common Data Model, you can go there is synthetic OMOP data that is floating around that you can use just to kind of start getting familiar with the data structure. So you can go to the odyssey.github.io website. Odyssey is OHDSI, I think, .org, or sorry, .github.io. And then you can kind of start familiarizing yourself with the vocabularies they use and the tables. Unfortunately, yeah, unless you're in the enclave, we really can't do much more. What you could also do is go to the N3C website, N3C. What is it? N3C, or like NIH.N3C. If you just Google N3C, you'll be able to find the website. There are data tables, there's dashboards that give more information about the cohorts, what data is available, and the process that's been used to kind of build everything. So yeah, you can use that.
There's a question here. It says, I may have missed it because I signed in a little bit late. How are you defining a positive diagnosis of long COVID?
With the ICD-10 code U09.9. And I guess to also do I saw a couple of questions about this. So the codes that we're receiving are from designated long COVID sites, or sites that have long COVID clinics. So these are a little more robust, I think, than just gathering all the different a bunch of diagnosis codes from a bunch of hospitals. So these are being limited to sites that we are partnering with, that N3C is partnered with, to actually bring in long COVID data. It still doesn't solve the issue of sensitivity. So there are still going to be patients in the N3C that do not have that ICD-10 code, but that probably have long COVID, and they just haven't been officially diagnosed.
A question, eligibility type question. If doing the challenge as part of a university course, will the professor be a teammate? Also, another related question is, can a student register as a team captain? These would be eligibility for Taylor.
Yeah, I would just recommend to carefully read the challenge announcement to understand the difference between whether you're competing on behalf of an institution or an entity versus whether you're competing as an unaffiliated team. And in this case, I would defer to your institution to determine any requirements they may have regarding your participation.
Thank you. I'm not sure if this was covered already, but there's a question about how to transfer data from Synapse to local data center.
The data is not in Synapse, it's in the N3C enclave, and the data in the N3C enclave cannot be transferred outside of the enclave. So you have to work within the N3C provisioned enclave.
Thank you. Will the flagship paper include details of methods and findings from the models developed by the teams? If yes, then should the team members expect to be co-authors on the flagship paper?
I can take that. Yeah. So yeah, most of the time, if we're diving into model details and model performances, and we're looking at some specific teams, then yes, normally the teams are co-authors in that paper.
And I have a question here about, is the project already available in the N3C enclave? What is the project code?
Yeah, so if you go to synapse.org/L3C, and then you go to the How to Participate tab, at the very bottom, it'll say request or submit a DUR. That will take you to the proper data use request to the with the right project name, and then you can just fill out that form, and then you'll submit that DUR, and then I'll work with you to get access. So the project is to answer the question, the project is spun up. People are being onboarded right now. There is data there available to start working with. So yeah.
Okay, so we have 5 minutes. We're going to take one more question. There was a question about which programming platforms are available in the enclave. In other words, Python, etc.
You can use Python, R, and SQL, and see it's Spark SQL, and yeah. If you're not familiar with the enclave, basically, yeah, I guess we'll go into further details at a future tutorial. And then also later today in the resources tab, I'll have links out to a bunch of different tutorials that you can watch and learn more. But yeah, it's R, Python, SQL.
Okay, thank you very much. So we're going to be addressing all of the remaining questions in our frequently answered questions document, an FAQ document that will be posted with the recording of this webinar at a later date. So all your answers will be there. We want to thank you for your interest in the L3C challenge, and we look forward to your participation.
Thank you, everyone.
Thank you, everyone.